Okay, I see a few people are still filtering in, but we're at 3 after, so I'm going to get started. So welcome everybody. I'm so glad that you are here joining us for our second webinar in our series, Homeless in the ED, Partnerships to Improve Care for People Without Homes in Emergency Departments. And this is our second session focused on harm reduction in the emergency department, and I'm very excited. This is a topic near and dear to my heart, and we have two great speakers that are joining us today. So I'm very excited about what they have to offer in the next hour to us. So my name is Kate Gleason-Bachman. I am the Clinical and Quality Improvement Nurse Manager at the Healthcare for the Homeless Council. I'm going to introduce our session today, and then we'll have a Q&A at the end. So I'll be running our Q&A as well. I have a little bit of housekeeping before we get started. I first just need to acknowledge that this presentation is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official view or endorsement by HRSA, HHS, or the U.S. government. Additionally, the content and opinions expressed in this presentation are solely those of the presenters and not necessarily those of the National Healthcare for the Homeless Council. A little more housekeeping. Some people are already introducing themselves in the chat, which is great. If you can introduce yourself and let us know who you are, where you're coming from and your organization, and where you're located, that would be great. You may have to set your chat to say everyone instead of just to the host. Sometimes it automatically sets that way. Just a quick reminder, we're going to have an evaluation at the very end. I'll say something about it again, but once the session ends, there'll be a pop-up and you can do an evaluation. Final disclaimer is just that this presentation is about folks who are coming into the ED and who use drugs, and a lot of those folks struggle with wounds, and so there are some wound images, and I know people often like a heads up about that. So that's just a heads up that there are some wound images in the session. So I'm just going to very briefly introduce the session and then our speakers, and we'll move on to be able to hear what we are all here for, which I'm very excited about. So if you were in our last session, we talked about the challenges for folks experiencing homelessness who are seeking care in the emergency department and kind of the challenges around coordinating care between healthcare for the homeless outpatient settings and then the emergency department side. We know people experiencing homelessness disproportionately use the emergency department, are often coming in with very complex needs that cannot necessarily be fully met by the ED. And then, of course, we know there are challenges around coordinating care outside of the emergency department and getting people what they need on the community side as well. If you missed that session, it's no problem. It's recorded, so you'll be able to access that session. So we really laid some excellent groundwork there. And today we're talking about folks who use substances, and this kind of adds an additional layer of complexity for people who are experiencing homelessness. The barriers become even more complex when we add this element in. And as we heard in our last session, in Boston, they found 60% of the folks that they surveyed who were experiencing homelessness also reported a substance use disorder. So we know this is a challenge that a lot of folks are facing. We have seen overdose rates really skyrocket, sadly, during the pandemic. And so this is an issue that is really ongoing and is challenging for folks. On the emergency department side, people are seeing complex cases, people with needs across the board in terms of medical care, behavioral health care, substance use, and then of course, basic and social needs, which all need to be met and can't necessarily be done in the emergency room. And for folks who are using substances on the outpatient side, a lot of times fear of withdrawal management, inadequate withdrawal management, and a lack of harm reduction approaches is a big barrier to people seeking care. So we also know on the outpatient side, providers are seeing people who may be appropriate for the emergency room or appropriate for inpatient care, but who are really hesitant to go there. And so we see people receiving care that is not necessarily in the best place for them to receive it. There's a lot of fragmentation of care. It's challenging to coordinate all the things that people need on top of the huge challenge of substance use that people are facing. So that's why we're here today, and I'm very excited to hear from our two speakers, both of whom are excellent clinicians with a lot of experience in this area, and who I think are going to have a lot of really important takeaways for all of us. regardless of what your role is, to learn about what's happening on either side of this equation and how we can kind of close those gaps and have some cohesive coordination of care is going to make a big difference. So I'm very excited about that. Our two guest speakers. So Lydia Williams is a board certified family nurse practitioner, and she's a certified wound ostomy continence nurse. She has over 10 years experience working with people experiencing homelessness, and she is a nurse practitioner with Project Home, which is a healthcare for the homeless setting here in Philadelphia, which is also where I'm located. She sees people for primary care, and as part of her practice, prescribes medications for opioid use disorder. She works across settings, and so she's a primary care provider working in an office-based setting, but also works with people experiencing homelessness through street outreach and also home visits for folks who are in Housing First permanent supportive housing. Brian Work is an associate professor, hospitalist, and addiction medicine physician at Temple Hospital in Philadelphia. He has worked as a volunteer physician and a board member at Prevention Point Philadelphia, which is Philadelphia's syringe support service, for over 20 years. He works in the hospital supporting addiction medicine in the emergency department and on the floors, and also works in the community supporting people who use drugs, and also working directly with HCH providers around coordinating care for people who need hospitalization. And with that, I'm going to turn it over to Lydia.
Let me unmute myself. Hi, everybody. I'm really happy to be here to discuss this important topic. So I'm going to share with you some of the strategies my colleagues and I use to advocate for harm reduction for our patients when they're in the emergency department. So we believe it's a shared responsibility amongst multiple settings, and by doing this, it will benefit the patients and the providers. When harm reduction isn't at the forefront when we're sending people to the emergency department, it creates a lot of burden on all of us. So a burden on the patients resulting from incomplete care because they are leaving AMA or early self-discharge due to inadequate withdrawal management. It puts a burden on the emergency department, physicians and staff, from patients returning often for repeated visits, and this feeling that they are providing care in isolation due to the fact that a lot of times patients are coming in and they have limited access to previous medical histories or treatments that patients have done, as well as patients coming in times when they are intoxicated and unable to give history, or due to their mental illness, there is not really a good history that can be taken. So everyone would benefit from us helping people to stay in the emergency department and the hospital if that's what's needed to complete treatment. We have found it has decreased the likelihood of repeated emergency room visits, as well as patient discharges like AMAs. It has decreased the likelihood that whatever disease process they went in for will progress to a rate that could cause severe disability. And it has increased the likelihood of follow-up care and recovery. Next slide, please, Kate. So one of the ways that we support people for maximum success in the emergency department, in the primary care and outpatient setting, is we do a really good job of preparing our patients for what to expect in the emergency department. So this is like explaining the reason why I want them to go and my concern if they don't seek care at an appropriate time. And this is not to like catastrophize the situation. I don't generally say to people, like, if you don't go to the emergency room today, right now, as soon as you leave here, you're absolutely going to lose your arm. I find in doing that, from watching other providers who have done that in other settings, and my patients talk to me, they don't like that. And it decreases their trust in your professional opinion. They think you're just trying to tell them what you want them to do versus really trying to collaborate with them on what they should do in regards to what's best for their care. So I like to print out anything that I can in the office. So whether that's like a medication list, any past medical history that we may have in the computer, vital signs, any labs. So, you know, in our setting, I could print out the visit summary and that could have a lot of that information on there. Believe it or not, there have been times where I have actually printed out my completed notes so that they could see what we talked about. They have other information in regards to their history as well. If possible, talk to them about any diagnostic studies that are going to be done. EKGs, labs, MRIs, CTs, so that they know when they go in what to be prepared for, so that they can plan in their mind, okay, I'm going to go in, this is probably going to be done. Because a lot of times people like to get things in order, I find, in this patient population before they go to the emergency department. That's why we also find it really helpful to discuss if we think inpatient admission is going to be possible or likely. Because I have had a patient before go to the hospital after I told her to do that, and she wasn't really clear that she was going to be able to stay. I didn't really prepare her for the fact that she probably would need to stay. And she ended up leaving because she didn't know she was going to stay, and she couldn't find anybody to feed her cat. So she said, I had to leave. I had to go feed my cat. And then she ended up going back the next day. But when she came back the next day, her arm was in much worse condition. So had we talked that through, we could have probably talked about that and figured out a way to help her to plan to do that. I'm fortunate enough to work with a Housing First organization. So we work very closely with the case management services from that organization. So with our patients, we are able to rely on the assistance from case managers and other service coordinators to help the participants get things in order in their home life so that they can take care of their health. Okay, next slide. So provide as much information to the emergency department prior to or at patient arrival. So sometimes I'll call ahead, other times I will present the patient with an envelope of things, like I said, the visit summary, the med list, outpatient information to give to them. And sometimes I'll call the charge nurse to give her a heads up, because then that way it puts people on notice. It's very busy in the emergency department. We know, unfortunately, right now, there are plenty of staffing shortages in healthcare. So as much information as we can provide to smooth out the process and to speed it along so that people can get care is better. And then one thing that I feel like recently has really worked well to keep our patients who are substance users and who are homeless is to advocate immediately upon arrival to the emergency department that they have an addiction medicine and psych consult upon arrival. Because there have been times where they get there and they're calling us and they're saying, I want to leave, they're not giving me enough. And then they've been in the emergency room for maybe about 6 hours. They're already starting to go on withdrawal. And then it's kind of too late to try to hurry up and get addiction medicine on board at that time. So if you request it immediately, when we've done that, we've had increased success with being able to keep the patient in the hospital. And then the final thing I want to say about this is it is really important to provide a direct office contact in the event of additional questions or requests for information. Not the general office number that's going to go through the switchboard, a direct number to a clinician, a social worker, somebody in the office who has easy access to get to the medical record and give information to the emergency department if necessary, as well as giving it to the patient so that if they need to tell you things or they need help or they're considering leaving, you have the ability to try to talk to them to see what it is that you may be able to advocate for so that they stay. Okay, so I'm going to hand it over to Brian so he can talk about how to support patients transitioning from transitioning from outpatient to the emergency department and to inpatient and all of those things. Brian.
Thank you so much, Lydia. All of what she said is so tremendously important. So as Kate said, I'm a doctor at Temple University Hospital, but also have been at Prevention Point, Philadelphia for the last over 20 years. This is a picture of a Prevention Point. It's in the Kensington section of the city, which is very close to Temple University Hospital. It is ground zero for the opioid and overdose epidemics in this region. Next slide, Kate. Okay, so I am fiercely proud of Prevention Point. We are the largest syringe exchange in the country, over 6 million syringes provided last year alone. And we're also the most progressive in many ways. We have 5, soon to be 6 medical clinics in the house, full service HIV, full service Hep C clinic. And we are a syringe exchange, but we're really now a multi-service public health organization with all of these services and more. Next slide. Okay, so let's ask ourselves first, These are some, I'm sorry if these are disturbing to some folks. These are some pictures of some wounds of folks who took a very long time to come to the hospital. The upper left is necrotizing fasciitis, the flesh-eating disease, and she wasn't going to come to the hospital. You can see in that picture, her skin is starting to slough off. She ran into her nurse practitioner at the wound care clinic, who popped her in the back of her car and took her straight to the hospital. Those are the surgical, the next two pictures, the surgical debridements of what was necessary to heal that wound. And then, you know, that hand is typical. Those arms are some of the worst trank wounds. You can ask me questions about that later that I have ever seen. They're treated like burn victims. I'm going to go over her particular case in a little bit. Now, my bet, look at that hole in that guy's cheek. I bet that if any of us, any of you, had a hole in the side of your face from which spit, pus, and food came out every time you talked, you would have gone to the hospital long before that. So why do they take so long to go to the hospital? Well, they're terrified of laying in withdrawal for hours to days. People say it's the worst feeling that one could possibly have, and they're also treated as less than human. Great disrespect. Unfortunately, there's still horrible discrimination on behalf of many healthcare providers toward those with IV opioid use disorder and homelessness. Next slide, Kate. This is an actual text I got. It's a prevention point client who ended up coming to the hospital. I took care of him, and he's calling me a great doctor. But look why I'm such a great doctor. I don't think I've ever had a doctor that actually showed me they cared about how I felt and talked to me like a human being and not a piece of crap because I use drugs. So I am a great doctor just because I treated him like a human being and not a piece of crap. That shows you how people expect to be treated when they come into the hospital. Next slide, please. So I just want to talk a little bit about ethics here. You know, we all take some manner of, or most providers, pharmacists, nurses, social workers, and physicians take the Hippocratic Oath. So I look at all of this here, but I want to draw your attention particularly to all measures. All measures doesn't just mean hanging the high-powered antibiotics, cutting into the wound. It means controlling the withdrawal as well. All measures. Next slide, please, Kate. Because if patients, Lydia mentioned this already, if patients lay there in withdrawal, they will leave against medical advice without completing treatment for the conditions that threaten life and limb. And if that occurs, and it's due to treatable withdrawal, then we haven't taken all measures, we haven't treated their withdrawal, and we just violated the Hippocratic Oath, and any other sorts of providers would have violated their oaths, and that's not why we went in to healthcare and to the helping services. Next slide, please. Okay, so let's talk about how we actually get patients into the hospital. Lydia talked about this. I'm going to give kind of a practical example or tell you blow by blow what happens. First, it starts with establishing trust in the field at the wound care van. These are prevention point wound care vans right there in Kensington, about a block from our building. And it's essentially telemedicine. The nurse or the NP sees the patient, sends me a picture of the wound, or gives me the clinical scenario if they're very sick and hypotensive and possibly septic, meaning they're getting ready to go into shock and possibly die. And we talk to the person on speakerphone from the wound care van, the clinic provider, the patient, and myself. We have a joint discussion, joint decision making. We let them know that somebody in the hospital is aware of what they're going through. I let them know that I am a prevention point doc who knows our folks and their issues, and I'll advocate for them in the hospital. I then ask the basic questions that let me know about their use. How many bundles of heroin and fentanyl do you use a day? A bundle is about a baker's dozen, 10 to 12 bags. And how much do they use daily? And then what is their, what we call get well dose? How many bags of heroin and fentanyl do they have to use if they are in withdrawal? This is all part of partnering with the ED, the physicians and the staff, so they know about the patient coming in, what their medical issues are, and what they will need for withdrawal control. This lightens the load for the ED because I know that they are always terribly busy. Now, the next step is actually getting them to and into the hospital. If they have a cell phone, it's easy. We can simply get them to the hospital, give them a ride, put them in an Uber or a Lyft. preferably when I'm working, and the patient can call me when they're in the waiting room. Now, however, sadly, most of our chronically homeless folks don't have a cell phone, and Prevention Point or Pathways to Housing employees or volunteers can take them and call me from the waiting room. I then go meet them briefly in the waiting room, and that's crucially important. That's that warm handoff that is so important in establishing trust. And then I thank them for coming in. I often give them a hug, and tell them that I'll advocate for them while they're in the hospital and help in aggressively controlling their withdrawal. I then go and talk directly to the ED emergency room charge nurse and one of the ED attending physicians, or I do this by phone if I'm not in the hospital. I make them aware that the patient's here, what's going on, and how much opioid they should be given right away, stat, as soon as they get into their room or in their section of the ED. Again, this is partnering with the ED to remove some of the burden of taking care of this often difficult and time-consuming set of patients. Let me tell you, I love these patients. I've been working with them for 26 years, but also I know they can be difficult patients when their withdrawal is not controlled. And I know how busy the ED can be, and I want to make it easier for the ED. If we do control withdrawal quickly and aggressively, almost all those folks with IV opioid use disorder are very pleasant and adherent or compliant. And this makes it easier for the ED physicians and staff. And also, a patient with their withdrawal well controlled will be more likely to agree to scans. What Lydia talked about, she prepares them for these things, but if they're out of withdrawal, they'll agree to scans, studies, labs, and this results in shorter ED stays, either from shorter time to discharge or shorter time to get them up to the hospital floors. If they are in withdrawal, let me tell you, people don't want to go get scans done. They don't want to have their blood drawn. It just eases the pathway for everyone. And it's a win-win. The patients get their withdrawal controlled and the providers have a much easier time of things. Now, I want to point out that a lot of this relies on me and several others in the hospital who take on this work. And any system that relies on one or several people is bound to fail eventually. We're working very hard to find more staffing so that we can make this a standard part of care for folks. But as you guys know, it's all about funding, and services for this portion of this population of patients is not always easy to come by. Next slide, please. So what do we do in the hospital? How do we control their withdrawal? Well, as you guys probably know, we always prefer to give medically assisted treatment, also known as medications for opioid use disorder, really Suboxone or methadone. And because of the long-term mortality benefit, you are twice as likely to be alive at the end of the year if you're on Suboxone or methadone and you use IV opiates. However, for our folks with very heavy use, 1 to 4 bundles, that's about 12 to 48 bags of heroin and fentanyl a day, Suboxone or methadone are not options when they're first admitted to the hospital. Now, I have whole lectures on different aspects of this very issue. I don't have time to talk about it all, but if you want to ask questions at the end, I'd be happy to field those questions. So we do have a very robust addiction service at Temple, of which I am a member, and it's our job to attempt to get folks on Suboxone and occasionally methadone over the pendency of their hospital stay. So, because we can't do that right at the start, what our hospital has settled on, and what other hospitals do, we are not the only one, is give pure opiate agonists. That is to say, extended release oxycodone or OxyContin, and immediate release oxycodone on top of that. We also give IV hydromorphone or Dilaudid, either by intermittent IV dosing or by patient-controlled anesthesia, which is PCA. We do that for additional pain and withdrawal control as needed. Common doses. Now, I know many of you aren't providers here. This shocks providers. Common doses would be 80 to 300 milligrams of extended release oxycodone or OxyContin every 8 hours, whether they ask for it or not, in addition to 40 to 150 of immediate release oxycodone every 4 hours as needed. They can ask for that for additional pain or withdrawal. And remember, we do this because our primary goal for folks who have extremely heavy use and who we cannot place on methadone and Suboxone immediately in the hospital, is to allow them to stay in the hospital to complete treatment so they don't die of their major medical problems or have something like an amputation. Remember the Hippocratic Oath. We are bound to do this. And I like to sum this up by saying, you cannot get into recovery if you are dead. We have to keep people alive so they can get into recovery. Now, there is understandable discomfort with these enormously high doses of opioids. The doses this large are almost never, if ever, given in the hospital. But we've been able to overcome resistance and discomfort with education. And here's how we roughly craft that argument. Next slide, Kate. Okay, so the DEA regularly tests confiscated drugs to assess the percentage of each drug in the sample and what adulterants are present as well. And then our Temple University Hospital Toxicology Department, which also as the majority of the addiction medicine department, they use this data to create rough equivalencies of heroin, fentanyl doses and amounts to other opioids that we give in the hospital. Now, this is not to be used for direct conversion. This rather makes a conceptual point. This is a graph of opioid strengths from that data. Now, strengths of all opioids are measured in morphine milligram equivalents, or MMEs, where 1 MME equals 1 milligram of IV morphine. One bundle of heroin and fentanyl, I want you to look at this on the left, equals roughly 2,000 MMEs. That's 2,000 milligrams of morphine a day. And remember, our folks are using 1, 2, 3, 4 bundles. So that's 4,000, 6,000, 8,000 milligrams of IV morphine a day, the equivalent of that. And they're wide awake on the street when they're using that. And look at this, the equivalent dose of OxyContin 100 milligrams every 8 hours, so 300 over the course of a day, is only about 500 morphine equivalents, or 500 milligrams of IV morphine. The point here is that this is orders of magnitude less. So even if somebody's using 2 bundles, when we go up to 200 every 8 hours or 300 every 8 hours, it's still orders of magnitude less than their, what I call their home dose. That's the dose that they're using on the street. That I would call that 2,000, that's what I would call that 2,000 milligrams. So it's orders of magnitude less, so it is safe, even though they are huge, shockingly large doses. Okay, next slide, please. All right, so the primary goal, I said, is to keep patients in the hospital for treatment of their life-threatening medical conditions. However, there is another main goal. This is to keep up their tolerance while they are in the hospital. If you remember nothing else from what I say, remember this fact: tolerance is harm reduction. So everybody with substance use disorder, if they have a period of decreased use or no use, like coming into the hospital where they get less than they normally would, they do the exact same thing when they can then use their normal amount. They use exactly the same amount that they did before they came into the hospital or before they came into jail. And then when they do that after they get discharged from the hospital, they have no tolerance if we have not kept up their doses of opioids in the hospital. So even if we don't manage to get them on Suboxone or methadone, which is great, which is where the mortality benefit lies, we still have given them protection in the short term by keeping up their tolerance, because we don't treat folks with the goal of saving life and limb only to have them overdose and very possibly die after leaving the hospital. Now, just very briefly, discharge from the hospital to the outpatient setting. So after discharge, it's difficult for our folks to follow up at a traditional hospital and clinic-based wound care and infectious disease clinics or any other clinic they need, because they are high barrier care. You guys know this. You go to your doctor for an appointment, you're a half an hour late, an hour late, and they say, you got to come back next week. I'm sorry. So they, our folks, remember, live very chaotic lives on the street. I know you guys know this. They're without cell phones, watches, or other methods of transportation. So you tell them to come back in 2 weeks at a particular time, that it's something that may be a mile away. That just isn't going to happen. So what instead we do, we have had much greater success by sending our folks to prevention point and pathways to housing wound and medical clinics. Those are low barrier care. Now be careful because the next slides are very graphic wound care slides. Kate, next slide, please. This is Ella. She's a tremendous success story. She was 3 of those pictures that I showed in the beginning. Those are very bad trank wounds. You can ask me about that later. These are, as I said, some of the first, the worst wounds I've seen. 1 through 5 is in that time that we were trying to get her to the hospital, but we couldn't. We totally healed these wounds. So number 6, that's when she was in. I got her to come into the hospital. I took care of her for a couple of days. I couldn't keep her any longer than that. She got her surgery. That's picture number 6. And then 7 through 10 is at our clinic van at Prevention Point. Low barrier care. You come whenever you damn well have the time and when you can get there, and we will see you. And so that, along with the skin, and let me say that these wounds just shortly after that picture in number 10 totally healed. So that low barrier care, along with the skill of our excellent wound care nurses and wound care nurses, is what leads to such success. Kate, that's all I got for right now. Go ahead. Lydia, I think.
Okay, so I'm gonna come back and just kind of give some of the conceptual things that we do to support a patient like Brian was just talking about in the hospital upon discharge. Okay, so as outpatient providers, if we have a patient that was in the emergency department, but especially in inpatient admission, what we try to do to support them for maximum success after discharge is we try to be prepared. So we inquire about a prospective discharge date, and we have nurses and other people on staff who check the hospital list query portal daily to see if patients are in the hospital. And we try to collect whatever documentation we can before the patient is discharged so that we're able to review it and case conference and come up with a plan so that we're all on the same page as a team, okay? If we become aware of an impending patient-initiated discharge. This is not a patient who's going to stay in the hospital, but if a patient lets us know that they want to leave, or we read the notes that say that the patient was saying that they want to leave, we try to call whoever is the inpatient provider, whatever service they are on, to discuss, hey, I saw this person was planning on leaving. I know you guys think that they should stay, but what outpatient management options are available to them? So if they were on IV antibiotics in the hospital, what would be the oral equivalent that would still cover the bacteria and organisms on the outpatient realm? How soon would they need to follow up with infectious disease? What topical wound care do you think that we need to do? All of those things are really important. And if there's one thing that I could say in addition to coordinating with the inpatient staff, is to just give them your contact information too, so that you can have them reach out to you to let you know things as well. I've done that. I've called the service before, gotten some information, and then next thing you know, the provider is calling me and saying, hey, so-and-so is going to be going home. I know you guys can set up, you know, discharge and specialty appointments. So we can get a jump on that before the person even comes out of the hospital. So there isn't this time lag of, oh, I don't know how soon I'm supposed to follow up, or they told me they were going to call for an appointment. We tried to take some of that, the load off of the patient, as well as ourselves ahead of time. Okay. And then
Lydia, can I just say one thing there? Yeah. I'm also a hospital, so I'm one of these inpatient doctors, not just as an addiction medicine doctor, but taking care of these patients for their medical conditions. And what Lydia said is so true. When I have a number that I can contact to get people to just a case manager that they might work with, I then feel comfortable that I can discharge this patient to at least a somewhat safe environment. And so it is so crucial. Before COVID, our prevention point, folks used to come into the hospital, sit with the patients. They would talk to us. We knew who they were and we could call them. That hasn't been possible since COVID. So we do get phone numbers, and it is so tremendously helpful.
Thanks, Brian. And then one of the things that I feel like is an underutilized resource in all settings is coordinating with your local street outreach team. They are an invaluable resource to us, or some other type of community health worker organization that you may have access to. A lot of times outreach has a connection with these folks from coming in contact with them when they're like in Kensington. I'm talking about in Philly. So I can reach out to the outreach team in that area and say, hey, listen, so-and-so's in the hospital. They're saying that they're going to be getting discharged this day. Do you think you could maybe meet them and pick them up and bring them into the office, or meet them and let them know that they have an appointment scheduled with me on this day, or that I want to see them, or whatever, so that the patient knows that I'm in the loop with care. And then from the emergency department side, if it's possible, or the hospital side, I'll say, even if the person is inpatient, this is one thing that I feel like is a super easy thing to do, that if you could take away anything upon discharge to make the transition to outpatient so much easier, it would be to please send the medication to whatever the patient's normal pharmacy is. I don't know how many times there has been like this whole, like, spending hours trying to figure out where the medication went, you know, especially if it involves like Suboxone or controlled substances, because you have to have the pharmacies back out the prescription if you want to prescribe it, and if they fill it. It's just a lot of work. It will save time. It will be so much easier for us to coordinate care and make sure that the patients get the medication. Sometimes the hospital pharmacy, I know at some of the hospitals in Philly, it is not the easiest place to navigate. It's not easy to get to. They may have to pay a copay when they get there, and they don't have any money. So when you send it to their pharmacy, they're familiar with it, they know how to get to it, they're comfortable with the staff, it just makes things so much easier. And then also knowing local clinics that specialize in healthcare for the homeless and addiction treatment services. So knowing what clinics like Prevention Point have holistic services. Not only do they have primary care or wound care and other things, they also provide addiction services so that the person can get care in one place. These patients have a fear, as we talked about, of engaging in the healthcare system. So if we are able to provide multiple services in one location, and you're able to get a list of places that do that, they're going to be more likely to follow up and to continue care in those places where it's like a one-stop shop. And then once again, for the emergency department, having a relationship with local street outreach and inquiring about any mobile providers that are on the street providing care. Right now at Project Home, we have a street outreach medicine department where I'm a part of. I'm there. I also do home visits, but we go out, we have providers out there 3 days out of the week. And we also have a nurse that's out there seeing patients, and we are doing primary care where the patients are, right there on the street, especially for folks who are very reticent to come in. These folks have lots of issues where they have transportation issues and trouble getting to clinic. So we are able to access them right where they are. So that's key as well for the emergency department. Next slide, Kate. You can move to the next slide, Kate. So Brian and I are going to kind of talk a little bit about some things that we feel like could be like next steps and opportunities for the future. I'm going to let Brian start and kind of talk a little bit about the first two, and then I'll kind of come in and chime in on some of the other things.
Okay, so, you know, in order to make some of these approaches, like inpatient management of withdrawal, more acceptable, we need more published data. There's been one study published so far in Annals of Internal Medicine of folks using oxycodone immediate release in the hospital to control withdrawal, but many institutions will not start something unless there is a fair amount of data already. What we need people to do, and we are doing this now at Temple, is some of this is really easy. You track the people who are getting these large doses, the IV drug users by diagnosis, and then you see if those folks that receive the opioid agonist, OxyContin, oxycodone, stay longer than the other people, and do they get their treatment done? We need more data like that. That will allow us to do a lot more of this. Additionally, when you switch out, I want to just talk about, well, the continuity is so important. We talked about, Lydia talked about this. The key to continuity between inpatient and outpatient setting is a commonly shared electronic medical record, or EMR. Now, sadly, this is generally lacking between small NGOs in the community and the large university hospital systems. The reason for this is NGOs don't have enough funding to purchase a license for an EMR like Epic, one of the more dominant EMRs in the country. So Prevention Point could not afford Epic. We had to buy a smaller standalone electronic medical record. So what do? We have to do a patchwork sort of thing. We rely on our volunteer providers at Prevention Point who have access to Epic at their home institutions, Temple, Jefferson, University of Pennsylvania, and then they call us and we look them up in our in Epic in those systems and get the information they need. But again, this is few people in a patchwork fashion. It's bound to fail eventually. What we need is more read-only access for the NGOs, but Epic has been very stubborn at providing that at a reduced cost. And the last thing I would say is that to make these approaches inpatient much more acceptable, we have developed order sets for the OxyContin and oxycodone, order sets for our Suboxone, the microdosing protocol and the full dose protocol. We are now allowing the individual hospitals and residents to order these things on their own because they have been educated, but the order set is a form of education in and of itself. I think that's all I want to say right there.
So one of the other things I wanted to say about in the future, I think that there needs to be a greater emphasis put on having different outreach workers and community health workers in all settings. So in the emergency room setting, as well as in the outpatient setting, these people can really serve as like the bridge between these different environments to try to help and coordinate care so that neither the outpatient side or the inpatient or emergency room side feel like they have to do everything. These are people that really can help with discharge planning and help to make sure that the actual discharge planning that was put in place is carried out. Also, for those folks who are continuing to come back, these are people that can say, like, I've noticed this person's been here all the time, but they do primary care at X, Y, and Z. Let me call over to that office to talk to the office to see what's going on and if they've seen this person. So we've had that happen and it's been really helpful. And as Brian said, like, we do need more research, and not just research about like treating withdrawal, but research on how outpatient offices are able to affect change in regards to harm reduction while patients are inside, and like case studies and research on how these collaborative efforts and models increase patient care and improve patient care and increase the likelihood that people are going to take charge of their health. So thanks so much for your time. We are so looking forward to the questions about anything at all.
I second that sentiment.
Yeah, so if folks have questions, you can put them in the chat and then I will read them out for Brian and Lydia. And I just want to thank both of you. This has been, you have shared so much important information. I feel like, you know, so many of the things you shared were something, just a gem that we could go so far in depth on. And these are all things I think that are actionable strategies that we can take on the community and the inpatient ED side to make some change. So, I mean, I just really want to highlight the value of getting the addiction med psych consult. I saw a few people kind of lift that up in the chat. That's such an important thing. The warm handoff coming from community into the ED, and then for someone to be there in the ED and back again to the community makes such a huge difference. And I also just really want to highlight that idea of tolerance as harm reduction. You know, I think a lot of folks are frightened to give people medication when they're coming in with a substance use disorder. And that is really a way to shift people's thought to think about this as a life-saving measure. Providing people medications that maintain their tolerance is a life-saving measure. And I just think that's so huge. I see a question that just came through about from both of you about how to address stigma that may exist with colleagues or within organizational policies. Brian, I know you have done some work at Temple to get those order sets in place. Could each of you speak to kind of how you have addressed that?
Lydia, would you like to go first?
Yeah, so I had an experience recently where I was advocating for a patient of mine to get better withdrawal management. And I did, since, I know Brian's work and how they work at Temple. I did tell them, like, hey, we've had patients that have had success with this treatment at other hospitals, because they were very reticent to give her those high amounts. I also confirmed with them, because sometimes I think the providers inpatient may think that the patients are like maybe not being honest about how much they use, or saying that they use a whole lot just so that they can get more pain medication. So I confirm the amount that I have on file that I know that they're using to kind of back the patient up. And sometimes I'll just say to them to get them to understand, because I think the stigma comes because people believe that those who use drugs don't care about their health, which is not true at all. So I have had success as well with saying, like, listen, I understand that this person is using, but I have given examples of how, like, this person is taking steps to take care of themselves, and we really want to support them, to let them know, like, they are in treatment. They come in for their appointments on time for their treatments, even though they're using. Their use has decreased. We're working on them trying to take care of their health, so that they understand that this is not a patient that's just on our caseload at my office, but that we're not seeing and that we're not working with regularly, so that they know this person does have primary care and has support enough that they clearly care about their health if they're coming to see me every 2 weeks.
Thanks so much, Lydia. I work on this more in the hospital, and it's something I teach every day to my medical students and residents. I tell them I will beat them about the head and neck if they snap at a nurse who has a question or is reticent or shows a little bit of stigma. What I want them to do, and what I do, is when someone makes a comment, I just say, hey, can we just chat for a sec? And I start to explain things. I start to humanize things, because we know what it has the ability to combat racism or discrimination against the LGBTQ community. It's kind of the connection and explanation and knowing somebody. So I try to kind of help the nurses, the pharmacists, make that connection. And in terms of when folks are very frightened to give these doses, when a nurse says, oh, I don't know if I can give that, I don't excoriate them. I say, hey, let me draw you a little picture. And I draw that picture of the equivalent doses of MMEs. And I say, look, this is what you're getting. This is why it's safe. And I'll tell you, when I educate people and tell them also what the folks are going through on the street, most of the people are won over, or I'm not saying I won over everybody, but boy, oh boy, our nurses are have much less stigma, as do our pharmacists and other folks in the hospital, and my colleagues too. Oh, and one other thing, Lydia mentioned about these folks caring about their health. I talk about this a lot. We have direct lines of evidence that they do care about their health. So our HIV clinic at Prevention Point, Philadelphia, we have some of the better, if not best, undetectable viral load rates of any clinic in the city and region. And these are people, and best CD4 counts, these are people who are using multiple times a day, and they're taking their damn HIV meds every day as they're supposed to. They care about their health. They don't want to die. And also, our folks carry Narcan, most of our folks, and we educate people. You obviously can't reverse yourself if you're overdosed. So we tell people to use together. And some of our highest, some of the folks who have reversed the most people are our clients, not other people who are trying to help out in the community. One other thing I'll say I'll leave it there for now. Next question.
Thank you. There's a couple questions about funding. So can either of you speak to funding around how to fund or how to make an argument to fund a street medicine project, or any ways to leverage some of the funding that is out there right now, especially around opioid use disorder, towards these efforts, towards a harm reduction focus?
Lydia?
I feel like when you're talking about this, getting money for anything, I feel like you have to show some type of data, whether that's something as small as like a small PDSA study, something that shows them that these things, putting these things in place could help, and a way to show how doing this would decrease cost in some other way. You have to get buy-in from people in order to get money. So that's what I feel you need.
Yeah, and I'll say from the hospital and hospital system side of things, it can be devilishly difficult because particularly getting people into the hospital and getting them out. The hospital systems often do not see the benefit in funding something out in the community, or they like the idea that there's this NGO out there that'll kind of do a lot of this work. Why would they give them money when they can rely on these organizations? That's a big problem. This is not just Temple. This is I was at Penn for 20 years and the same existed there. It's very difficult, but I think Lydia's point is tremendously important. The more we get some basic studies out there, just small case series of how this helped and how these folks are high utilizers. That I think at Temple, we have so many people that we have in the hospital at any one time who have opioid use disorder and wounds or sepsis or bacteremia, that it's starting to hit the administration that, boy, oh boy, we should do something about this, because we can't keep these people in the hospital all the time and have them filling up half of the hospital. But there's no easy answer. I'm really sorry about that.
Like so many things, no easy answer. I see a question about addressing within a hospital setting resistance to treating people experiencing homelessness, resistance to, treating people who have substance use disorder. How can you address that, or how have you addressed that within your own system?
Brian, go ahead.
Well, in the inpatient setting, I think I hate to beat a dead horse here, but it's education, education, education. So we do it in larger forms with lectures. I've gone around and lectured to every nursing unit in the hospital, and I keep doing it because people need to hear this over and over. I have little lectures that take 20 minutes, half hour at their unit-based councils. I do that, and then it's also just pulling people over when they do ask a question or they do have hesitancy. Don't scold, don't excoriate, teach. And have a very kind, caring, loving approach to that other provider, my hospitalist colleague, my pharmacist that has to approve the medications, and the nurse who has to administer them. It really is about that. I have to say that in the past, I took a harder stance, like you really have to give this medication because this person will leave the hospital. I still get that message across, but it's more like, hey, let me tell you why this is safe. And I think that's so much of combating stigma as well. One other thing that I just wanted to say before, and I'll say now, is that in terms of people's reticence in giving these medications, nurses approving these medications, pharmacists, we have been doing this since I've only been at Temple now for 3 years, and we've been doing this at Temple longer than that. And guess how many overdoses we have had related to our administration of opioids? Absolutely zero in about 5 years. There were 2 non-fatal overdoses that occurred by people bringing in their own supplies. But why do they bring in their own supplies? Do they want to get high? No, they don't trust us to control their withdrawal. And that was only 2 incidences in 5 years, and it just took a little shot of Narcan and they were fine. So this is very safe, but it's education.
Thank you. Thank you both. I think I'm sorry, there were a couple questions we were not able to get to, but I want to give everyone a couple minutes at the end to complete the evaluation of the session. So thank you, Lydia and Brian. This was excellent. I think you gave so much valuable information, and takeaways for all of us. So thank you so much.
And I want to just say, guys, thanks so much for attending the session. Lydia and I cannot get to everybody. And I want you to be our emissaries. You go out and teach this stuff. I tell my medical students and my residents this. To have you out there spreading the word on this is going to be immeasurably helpful. And that, in fact, will combat a lot of the stigma that currently exists.
Yeah, Kate,
Absolutely.
you know, Kate and I work together in other settings. And what was the thing you guys used to go out and do at Jefferson? Was that the grand rounds? You guys would do a presentation about taking care of those who experience homelessness. And those things are really important. It's important to have people come into like medical schools and nursing schools to talk to students about this before they come out. So like, we may not be able to change the stigma of those who are already working, but we should be doing a lot of work to make sure that the future of medicine, nursing, and healthcare is not putting that stigma on people.
Mm-hmm. Absolutely. It makes such a huge difference to folks, and they want to be able to help and they don't know how. And so sometimes that education is just to show them there is a way to support and help people. And, you know, here's some steps you can do. So thank you. So this is just a plug for our final session of this webinar series. This is going to be next week at the same time on March 30th. We are going to talk about discharge planning and the role of medical respite in discharge, in making these connections and closing the loop for people between the emergency room, hospital, and outpatient side. The session will be a panel, and so I think it's going to be really fascinating. We're going to hear from folks. Respite care and discharge planning care coordination can look very different across different settings. So we're going to hear from different people about what their program is doing and how they are working as essential partners with emergency departments. Also a little plug for our conference. We're having an in-person conference this May in Seattle, National Healthcare for the Homeless Council, and the registration is open. So we would love for you to be able to join us there in Seattle. And that's it. So thank you all so much for coming. Thank you, Lydia and Brian. This was excellent. When this session ends, you will get an automatic pop-up for an evaluation of the session. And I would really love it if everyone could do that. It makes a huge difference to us. We really value that feedback, and we take all those ideas into consideration as we create more content and respond to our community. So I would encourage everyone to do that. And thank you all so much for joining us today.